Now we take questions. We'll give you questions from individual panel members. And, we have 5 minutes each. And I'll start with myself. And this is about the public option. As you know, and this is to Dr. Wolf or Dr. Woolhandler or both of you, as you know, the discussion draft would create a public option to compete with private plans to offer coverage within the new health insurance exchange. Uninsured Americans would choose to enroll in any of the plans in the exchange, either public or private. And there has been concern expressed in some quarters that this public option would inevitably evolve into a single-payer system. For example, last Friday, when the discussion draft was released, Scott Sirota, the head of Blue Cross and Blue Shield Association, warned, and I'll quote, that the proposed creation of a government-run health plan would jeopardize the coverage of 160 million people who receive their benefits through their employer today. An independent analysis by the Lewin Group estimates that tens of millions of people would shift to a government plan, dismantling the private market that is free to innovate without the political pressures that often stifle efforts to innovate in government programs like Medicare. Now, we're going to have Blue Cross Blue Shield and the Levin Group here tomorrow. But what I wanted to ask you today is whether you think Sirota is right. Will the public option strangle the private health insurance industry and become a single-payer system? I'll start with Dr. Wolf and Dr. Woodhandler.
We have heard the same things that you've heard, Congressman Poloni, that somehow or other the public option is really a Trojan horse or a stalking horse for a single payer. What that would mean would be that if a public option were to pass alongside with the private, that it would allow the public option to be as good as it can be. And essentially, if that were the case, which I don't think is going to happen, it might, in fact, lead to single payer. I think there is zero possibility that anything that anyone is remotely considering as the public option would lead to a single payer program. I think that it's more likely that it would give bad word or bad reputation to a public option because it would be so emasculated. I mean, at this point, I would say that the chances are 50-50 that either the public option will be completely scuttled, which I think is possible. President Obama said yesterday he wouldn't be opposed to signing a bill even if it didn't have that, or it'll be so emasculated that it won't be competitive as it should be with the private plan. So I just don't think that that's realistic at all. I think that this is sort of scare tactics from the right, which includes the entire health insurance industry. Stephanie, you want to add?
And Dr. Woolhandler, because I want to get to another question.
Okay. A public plan option is not single payer, nor would it lead to a single payer. As you've envisaged it in the Tri-Committee report, it's going to be an identical clone of private health insurance with a public label on it. And that still might be okay if competition in healthcare were about giving people care, but competition in health insurance is about not giving people care, about competing to enroll a lot of people and not cover them. And if you don't behave like that, if you don't misbehave like that, you go out of business in a competitive market. So a private insurance clone with public label is not going to solve this problem. It's really irrelevant to the problem of access to care. Well, and I appreciate the private insurance industry doesn't want it. They don't want any new competitors. But they're wrong when they say that what's here in this bill is going to lead to single payer. That's not true.
Well, I'm probably going to say something that you won't want to hear, but I'm beginning to feel more and more that since I'm getting so much opposition from the insurance industry that, the public option is going to hurt them, and so much opposition from single payers that the public option won't work, that I'm actually now believe that we have a great discussion draft because neither group likes it. But don't that's not a question. That's just my comment. I wanted to ask Dr. Woolhandler on the bankruptcy issue. I know you did this important study on bankruptcies and health insurance, and as you testified this afternoon, your study found that medical bills and illnesses contribute to over 60% of all personal bankruptcies. 3/4 of people with these medical bankruptcies has insurance at the start of their illness. It was a real eye-opener for me. In the discussion draft, we have consumer protections that would prevent the abuses of the past, practices like medical underwriting and pre-existing conditions exclusion and rescissions, which deny or take away coverage just when it's needed most. So what I'm happy with these consumer protections in our discussion draft, and I wanted to know, whether you thought the House discussion draft addresses some of these critical consumer protections adequately based on your research.
There's nothing in the draft that would have protected families from bankruptcy. The average family in medical bankruptcy had unpaid medical bills of about $17,000. And in your draft, you would allow people to have out-of-pocket expenses of about $10,000 per family per year. So in less than 2 years, if you had a serious illness, you could accumulate the $17,000 in out-of-pocket expenses that bankrupted families in our study. So the protections you have, maybe they're better than no protections, but based on the actual circumstances that drove people to bankruptcy in our study, no, the bill would not protect people from bankruptcy.
Okay. I know we're not going to agree on everything, but I do think that it's important that these insurance abuses be eliminated, and we're certainly making an effort in that regard. Thank you very much. A gentleman from Indiana, Mr. Boyer.
Thank you very much. Dr. Goodman, the legislation mandates a massive expansion of the Medicaid program that some believe could lead to well over 20 million Americans becoming enrolled then into the Medicaid program. First of all, I'd like to know your thoughts about this as a proposal, and do you believe that there will be a similar crowd-out effect as is currently being seen in the SCHIP program?
Well, I do, and I think that's what is intended. That when you make something available for free, even if the quality is not as good, people will tend to drop a high-priced alternative. That's what's happened in SCHIP. That's what happened in TennCare in Tennessee. That's what happened in Hawaii. So we have quite a number of examples of people dropping private coverage to take advantage of public plans. What happens in Medicaid is that it's really an inferior insurance plan. It pays, in many places, 40% below what the private market is paying. And so the Medicaid patient is the last patient the doctor wants to see at the end of the day. So you have increasingly long waits to see doctors, difficulty finding new doctors that will even see Medicaid patients, and pretty poor results when it comes to serious health care like cancer care.
And in those cases that you just discussed, where the crowd-out effect had occurred within the SCHIP program, what was the impact upon insurance premiums because of the crowd-out? They increase or decrease?
I don't know what the effect has been on insurance premiums. On the crowd-out, the Congressional Budget Office estimated that the bill that Congress passed in January that would put 4 million new children into SCHIP, as many as half those children would leave private coverage in order to enroll.
Dr. Goodman, I'm told your microphone may not be on, is it?
Can you hear me now?
Yeah, it's more concerned about the transcription, but we're okay?
Sorry.
Thank you.
When those children had private insurance, they could see almost any doctor, go to almost any facility in the area where they live. Once they go into Medicaid, they can see far fewer physicians, go to fewer facilities, and their choices are more limited, and their wait for care is longer.
There has been some comments with regard to that a public option plan would be able to compete on a level playing field with private insurance. Are you familiar at all at the tax revenues that are paid unto the states and the federal government because of the insurance, the tax on their revenues? I mean, if we were to have a public plan that would compete equally with private plans, my question would be, would we need to exclude these companies from state and federal taxes in order for us to be able to compete on a level playing field?
What a level playing field means to me is that the public plan doesn't get any advantages. It cannot do what Medicare now does and use the monopoly buying power of the state to push the rates it pays down below 30% below market. It can't use the criminal law to enforce its contracts when everybody else has to use the civil law. And it can't avoid the payment of taxes on revenues, and it's allowed to go bankrupt. But if you protect it the way Medicare is protected, having protections that private insurance does not have, then that's not a level playing field.
And that public option with regard to the coverage of health would be far greater than perhaps a private plan, would it not?
Well, I don't know, but I wouldn't object to competition if it's a real level playing field. If it's a real level playing field, you just create a corporation. You can call it a corporation, let it sink or swim on its own, and I don't think it would much matter. But if it has advantages that Medicare now has over private insurers, it would matter a lot. And that's when you hear these estimates from Lewin and others, they're assuming it would have the advantages that Medicare has that private insurers do not.
it's hard for me to imagine this competition to create a public option and say that it will be on equal plane with private insurance. And the reason I say that is I'm sitting here with my colleague John Shadig, and Joe Barton was here. There were 5 of us that worked really hard when we were creating the Medicare drug discount card program and then our analysis into the Medicare Part D, and we were trying to create choice and competition in the marketplace. At the same time, my Democrat colleagues were questioning whether or not that would ever be successful. In particular, the chairman, Henry Waxman, was very critical of what we were doing and wanted a government position in there. But in the end, we went pro-market forces, and were able to reduce the price. And matter of fact, we got all the estimates all wrong. In the end, we were able to save tens and billions and billions of dollars. Now trying to provide that same analysis into this one, to me, it creates a heterodox. And you're taking doctrine for which people know and understand and giving it a completely different definition. And so we're screwing up words, languages, and it just doesn't fit. I'll yield back.
May I answer that?
Was it a question? Go ahead. Okay. Sure. But before you go, let me just mention we have 3 votes pending. I'll hear from a couple more members and then we'll recess. But go ahead, Doctor.
Part D competition, I think, is working well, better than anyone predicted that it would work. But that's different than what we're now talking about. What most people don't realize is that Medicare is almost everywhere administered by Blue Cross. Okay? Now, do we really think that Blue Cross administering Medicare is any more efficient than Blue Cross administering other plans? Well, no, of course not. So why is it that Medicare has an advantage? It's because of advantages that are created by government, by law. So a level playing field would mean that anything administered by Blue Cross plays by the same rules. And then I think it really wouldn't matter whether we call it public or not.
Thank you. Chairman Dingell. Questions? Ms. Eshoo?
Thank you, Mr. Chairman, for holding these series of hearings, and to all of the witnesses. I respect and admire the work that you've done and your testimony here today. There are great passions around single payer. I know that from some people in my own district, others in California, and certainly people across the country. Let me ask you about something that I think is important to the American people. In fact, I think they kind of have it in their DNA. No American, I don't think, really likes like a one-size-fits-all. They really like to have choice. I know that, single payer doesn't provide that, but I'm asking you very sincerely, do you believe that this would, do you think that single payer could in any way preserve choice for patients?
Yeah. Okay,
because as I understand, single payer is it's the one system that is paid by one outfit, the federal government, and that's it.
Yeah. Okay. Well, from the patient's point of view,
we learned a lot
yeah.
from, and I was here.
Yeah.
I was here for the healthcare debate 93, 94. And if there was anything that I heard from my constituents was, don't force me into a plan. If I have what I have and I like what I have, that's what I want to stay with.
Well, the choice that patients care about is that they're able to choose any doctor or hospital they want. And, of course, that kind of choice is enhanced and expanded in single-payer. In single-payer system, you go to any doctor, you go to any hospital. So that's the choice patients care about. Once they know the bill's going to get paid, they don't care about who the insurance person is. They care about the doctor and the hospital. From the doctor's point of view, the choice we want is to be able to do what's best for our patients and not have to ask permission from some private insurance bureaucrat or be told we can only refer patient X to Dr. Y because of restrictions. So choice is actually bigger. The important
So
choice, which is choice of doctor and hospitals,
what the
bigger.
Democrats are proposing in the bill does preserve some choice that matches somewhat what you just described, and that is that they have a choice of doctors, they have a choice of hospitals.
But that's
So
actually
it's-
generally not a characteristic of private HMO coverage in this country. The private insurance
Well,
coverage
as it stands
frequently,
today,
yeah.
but I think that we have to ramp up what we're talking about because we're comparing and contrasting new ideas. We know what's broken. I mean, we don't need panels of people and all kinds of hearings to reiterate what's broken. We're looking at how to fix this thing. So, again, I mean, I admire your work. I really think that if we were starting from scratch, from total scratch in the country, it's probably what you all described today is what would be built. But we're not starting from scratch. And that's why I think a public option is so important. Can you tell the committee how you think a single payer system would affect innovation in healthcare, which I think is so important because we constantly have to be pushing the edges, the envelope out in our country on this. It's what makes the best part of caring for people in our country, the high end of it, something that is admired by people in different parts of the world. So can you enlighten us on that and how you think your proposal would do that?
And one of the things that gets focused on so much with single payer is that the government collects the money and pays the bills. Anyone can go to any doctor and hospital. But a very important element that doesn't get talked about very much is that you have a single data system. So that, for example, in Ontario, they can easily look at every patient in Ontario who got a certain prescription drug over a 2-year period, and then look to see how many of them had to get hospitalized because of something that is suspected to be an
that's
adverse reaction.
tracking the statistics. I'm talking about innovation.
Well, part of innovation.
Medical devices and biotechnology. Let me ask one last question here because I only have 17 seconds left. How do you pay for your system that you're advocates of?
Well, the beauty of single payers, it contains its own funding.
Well, how do you pay for
it? You simplify administration. Currently, administration.
What's the savings over 10 years?
It's $400 billion a year, so that's $4 trillion. You don't really save it because you take that same $4 trillion and use it to cover the uninsured and plug the holes in coverage for people who now have these crummy private policies. But you don't raise total health spending by a single penny. You just simplify administration, capture just under $400 billion annually by administrative simplification, and then you use that to provide care.
Thank you, Mr. Chairman.
Thank you. I'm going to ask Mr. Gingrey next, and then we'll recess after him.
Mr. Chairman, thank you. I'm going to go straight to Dr. Goodman with my questions because I don't think any constituents in the 11th of Georgia, any stakeholders, whether they're doctors or hospitals or especially insurance companies, would want to hear me ask any questions of Dr. Wolf or Dr. Woolhandler based on their testimony. I would like to address a couple of questions, though, to Dr. Goodman. Dr. Goodman, many of my constituents fear that a government-run council making health coverage determination for a government-run insurance plan will impede or stop their ability to receive quality health care and eventually result in a government-run health care system where it's bureaucrats in Washington controlling their health care decisions. Some of my Democratic colleagues say that a government-run plan will only provide choice and not lead to a single-payer system. Now, my concern, of course, is that it will. And the old expression, if it walks like a duck and it quacks like a duck, you can bet that it probably is a duck. And speaking of ducks, you mentioned long wait times in other foreign countries like Canada. In Norway, for instance, patients can expect to wait an average of 133 days for a hip replacement, 63 days for cataract surgery, 160 days for knee replacement, 46 days for bypass surgery after having been approved for the procedure. Well, Dr. Goodman, it seems that quality health care is not only the doctor you see, but the amount of time it takes to get through the door. In your opinion, are waiting times symptomatic and consistent with a government-run health care system?
Well, yes, and you get long waits because you make medical care free to the patient and you limit resources, and so demand exceeds supply at every margin, so you wait for everything. I might point out that we're getting a waiting problem in our healthcare system too. We're inching toward Canada without changing anything about how we pay for healthcare, and I'm concerned about that. On the health board, you know, I have to rely on Senator Daschle and the book he wrote and what he said about it.
The book titled Critical.
Was
that the book?
That Senator Daschle wrote about health care.
Yes, Critical, I think, was the name of that book.
Now, Senator Daschle pointed to the British example of the health board with the acronym NICE, and he said, what do? They compare treatments, and they compare cost, and they compare benefits, and they look at effectiveness. And quite frankly, in Britain, there is sort of a cutoff point. They don't want to spend much more than $35,000 to save a year of life. And that means that in Britain, people often do not get cancer drugs that are routinely available in the United States and on the European continent. So, yes, I'm very concerned about that, and I'm concerned not that the government is going to tell doctors what to do, because even in Britain it doesn't always tell doctors what to do, but that it will give cover to health plans that already have an economic incentive to underprovide to the sick anyway. And if the health board is saying, you know, that expensive drug is experimental and we really don't need to buy it, that's all the health plan would need by way of guidance in order to deny coverage.
Well, let me reclaim my time, because I did want to put out some statistics which speaks to exactly what you're saying, because you stated in your testimony that healthcare plays a leading role in determining the outcomes for diseases such as cancer, diabetes, and hypertension. As a physician, practiced 26 years, OBGYN, I cannot agree with you more. Focusing on cancer just for a moment. You mentioned that the 5-year survival rate of women diagnosed with breast cancer in the United States is 90% versus 79% for women in Europe. You also mentioned that the United States has a better relative survival rate than Norway for colon, rectal, and breast cancer, lower rates of vaccine-preventable pertussis, measles, hepatitis B. Given that we do live in a global economy where breakthroughs in medical science and technology can be shared with patients in other countries half a world away, I'm curious as to your thoughts for this disparity. What is the difference? These survival rates are significantly different.
First place, there's a difference in diagnosis. And remember, just to take mammograms. American women get more mammograms than Canadian women do. They get more pap smears than Canadian women. Then there's the treatment. And regardless of the state of medical science, people in other countries may not get the same treatment that we get. And then there's access to expensive but effective drugs. And in other countries, that is controlled more than it is the United States. So those are three things I would point to.
Yeah. I just like to go on record as saying I disagree completely with what Dr. Goodman is saying. I don't think that's supported by the scientific evidence.
Well, I would like to say that I have a paper here with more than 100 peer-reviewed studies that we drew on to make these statements.
We're going to have to.
Mr. Chairman, thank you. I realize my time is expired, and I appreciate Dr. Woolhandler's comment. And Dr. Goodman, thank you for responding for those two questions. And I yield back, Mr. Chairman.
Thank you. We have 3 votes, so we'll be back maybe half an hour or so. Subcommittee stands in recess.
Yeah, oh, yeah. Because they're